Assalamualaikum and good day. Today we are going to look at the neoplastic diseases of the bones. First, we look at the general approach to the bone tumors. The most important information for the diagnosis of bone tumors are the age, anatomic site, and part of the bone that is involved by the tumor. Other considerations include the tumor behavior, the ability to differentiate from benign to malignant, the association with damaged bone such as bone infarct, Paget's disease, and previous radiation, pain, and the radiological features. The primary bone tumors tend to be seen at a specific age group. For example, Ewing sarcoma is seen in children and adolescents and almost never seen in elderly. Chondrosarcoma, on the other hand, is seen mainly in elderly and rarely in children. Osteosarcoma has a bimodal age group incidence that mainly affects adolescents and also a smaller group of elderly. Knowing the age of the patient is important to determine the possible type of bone tumor they may have. Many primary bone tumors tend to occur during the height of skeletal growth, which is during adolescence. During this period, they tend to occur around the long bones, especially the longest and second longest bone in the body. The longest bone in the body is the femur, and the second longest bone is the tibia. This is why tumors that occurs in the adolescent age group are seen mostly around the knee. For example, osteosarcoma. Many of the tumors also tend to occur around the metaphysis during this period, which is the center for developing bone. The common primary bone tumors have the tendency to develop at specific sites in the bone. And for example, in Ewing sarcoma and fibrous dysplasia, they are usually seen intramedullary and around the diaphysis, whereas the osteoid osteoma is usually seen at the diaphysis at the cortex. Most of the primary tumors of the bone develop around the metaphysis. For example, osteosarcoma, chondrosarcoma, fibrosarcoma, osteoblastoma, enchondroma, fibrous dysplasia, and osteochondroma. Two important tumors that can develop at the epiphysis are chondroblastoma and giant cell tumor. When we look at the behavior of the tumor, whether they are benign or malignant, we see that benign tumors are far more common than malignant ones. The most common benign tumors are osteochondromas, non-ossifying fibromas, and enchondromas. Some primary bone tumors are difficult to classify as benign or malignant. For example, the giant cell tumor of the bone, which we will see later, is very aggressive locally but only rarely metastasizes. The WHO in 2013 classified it as a benign tumor. Among the primary malignant sarcomas, osteosarcomas have the highest incidence, followed by chondrosarcoma and Ewing sarcoma. One important feature of bone tumors is their ability to differentiate it from benign to malignant tumor. This is called dedifferentiation. For example, enchondromas can transform into a high-grade sarcoma, or osteoid osteoma can transform to a chondrosarcoma. There is a tendency for bone tumors to arise in damaged bone, for example at the sites of bone infarcts, radiation osteitis, Paget's disease, chronic osteomyelitis, and even metal prosthesis. Note that this accounts for a small fraction of bone tumors. Benign non-growing lesions tend to be asymptomatic incidental findings, but some tumors produce pain or noticed as slow-growing mass. Pain may be a symptom of growing lesions, locally aggressive lesions such as giant cell tumors and malignant tumors, pathologic fracture in benign or malignant tumors, and significant local tissue reaction to the tumor. Bone tumors usually have specific radiographic presentation, and the X-ray or plain radiograph is the usual first imaging technique for a suspected bone lesion. This is inexpensive and easily obtainable and is the best assessment for general radiological features of the tumor. At the end of the day, the diagnosis of bone tumors have to integrate the clinical features, the radiological features, and the histopathological appearance of the tumor. The histologic grade is the most important prognostic feature of a bone sarcoma. This table shows the classification of bone tumors, which are of major non-hematopoietic primary bone tumors. They are further categorized into cartilage-forming, bone-forming, unknown origin, and notochordal. Their behavior is either benign or malignant. For instance, for cartilage-forming benign tumors, there are osteochondromas, chondromas, chondroblastomas, and chondromyxoid fibroma, whereas the malignant counterpart is chondrosarcoma. The bone-forming benign tumors are osteoid osteoma and osteoblastoma, whereas the malignant counterpart is osteosarcoma. For the unknown origin, the benign counterparts are giant cell tumors and aneurysmal bone cysts, whereas under malignant behavior, there are Ewing sarcoma and adamantinoma. We will look at some of these tumors in the next sections.
We look at osteoid osteoma. It usually occurs at a young age and usually affects the long bones seen at the diaphysis. Males are affected more than females. Presents with bone pain usually at night, and the pain is relieved by aspirin. This is caused by excess prostaglandin E2 produced by the proliferating osteoblast. The tumor size is usually less than 2 cm in diameter. Compare this to osteoblastoma. Grossly, osteoid osteoma is a circumscribed mass, usually red, and is composed of trabecular bone, usually less than 2 cm in size. Microscopically, is composed of thin spicules of osteoid and woven bone rimmed by osteoblasts. There's no significant nuclear TPS seen. Other benign bone-forming tumors include osteoma. This is usually a solitary tumor, often seen in the skull, and it affects middle age. And it may obstruct sinus cavity, compress the brain or the eye. Osteoblastoma has similar features to osteoid osteoma, but it is more than 2 cm in size, and the pain is unresponsive to aspirin compared to osteoid osteoma, which usually affects the long bone. Osteoblastoma usually affects the spine. Now we go to the malignant bone-forming tumor, which is osteosarcoma. This is the most common primary bone sarcoma, and it comprises of 20% of primary bone cancers. Osteosarcoma is usually seen in young adults. The peak incidence is around second decade of life. This is where the period of the most active skeletal growth is, but it has a bimodal age distribution. It can also be seen in the elderly. The anatomic site that is involved is usually the metaphysis of the long bones of the extremities. 50% occurs around the knee, affecting the distal femur and the proximal tibia. Males are affected more than females.
70% of osteosarcomas have acquired genetic abnormalities. They are associated strongly with genetic mutation such as retinoblastoma gene and tumor suppressor p53 gene. They are also associated with MDM2 and CDK4 genetic mutation, which inhibit p53 and retinoblastoma function respectively. Osteosarcoma develop at an increased rate in adolescents who had retinoblastoma as infants. They have a 1,000-fold increased risk to develop osteosarcoma, and patients with Li-Fraumeni syndrome also have an increased rate to develop osteosarcoma. In the elderly age group, osteosarcoma is usually associated with Paget's disease, radiation complications, or bone infarct. For example, in the early 20th century, the women painted their watch with radioactive phosphorus, And they usually do this by licking the brushes and putting the radioactive phosphorus on the brush. Yeah. And the radioactive phosphorus accumulates in their jaw bones. So these women usually develop osteosarcoma of the jaw. This diagram shows the major sites of origin of osteosarcomas. The most common site is around the knee, which accounts for about 50% of the osteosarcoma incidence.
Osteosarcoma has a characteristic feature on X-ray. It shows this sunburst appearance or Codman's triangle. The picture shows distal femoral osteosarcoma with prominent bone formation extending into the soft tissue. And you can see that at the arrow there is lifting of the periosteum by the tumor cells, and this is known as Codman's triangle. Grossly, this is what osteosarcoma looks like. This is osteosarcoma at the upper end of the tibia. The grayish white tumor fills most of the medullary cavity of the metaphysis and extending into the diaphysis. It has infiltrated through the cortex, lifting up the periosteum. That's where the Codman's triangle is seen, and it forms a soft tissue mass on both sides of the bone. Histologically, it is an osteoid producing tumor. You can see the osteoid, the pinkish material surrounded by the nucleus of the malignant osteoblast, and sometimes it's called the lace-like pattern deposition of osteoid. You can see that some mitosis is present, and the neoplastic cells are located in the spaces between the osteoid deposits.
Osteosarcoma typically present as a painful, progressively enlarging mass. It may present as a sudden fracture. All osteosarcoma patients are assumed to have occult or unidentified metastasis at the time of diagnosis. Treatment generally includes neoadjuvant chemotherapy or chemotherapy given before the main treatment, that is surgery, and post-op adjuvant chemotherapy. Chemotherapy has greatly improved osteosarcoma prognosis, with 5-year survival reaching 70% in patients without overt or frank metastasis. Osteosarcoma metastasizes hematogenously to the lungs, bones, and brain. And those with overt metastasis, recurrent disease, or secondary osteosarcoma has poor outcome with a 5-year survival rate less than 20%.
Next, we look at osteochondroma, also known as exostosis. It usually affects people in the first 30 years of life, and it involves the long bones, especially around the metaphysis. It is the most common benign tumor of the bone, and it is a benign tumor forming bone and cartilage cap. It may be solitary or multiple, but if it is multiple, it can be associated with sarcoma. It may arise spontaneously or as a result of previous trauma. On X-ray, it shows a pedunculated bony outgrowth, and on histology, it shows mixture of bone with a uniform cartilage cap. Complications of osteochondromas include fractures, bone deformities, and most importantly, the malignant transformation, and treatment is resection of the bone tumor. Another benign cartilage forming tumor is chondroma. Usually affects the male teenagers and young adults. It's usually seen at the hands and the feet, and it involves the metaphysis. Usually it's a solitary tumor, but if it's multiple, it is associated with Ollius disease, and this may undergo sarcomatous change. If it is associated with hemangioma, it is Maffucci syndrome, and people with this Maffucci syndrome is at risk to develop other malignancies such as ovarian carcinoma and brain glioma. Other benign cartilage-forming tumors are chondroblastoma and chondromyxoid fibroma. Chondroblastoma affects the teens. It involves the epiphysis, usually is painful, and recurrences are not uncommon after curettage or when the tumor has been removed. Pulmonary metastases occur rarely in lesions post-fracture or post-curettage. And chondromyxoid fibroma also affects the teens, and the site is metaphysis. It presents with dull pain, and it may recur, but there is no threat of malignant transformation or metastasis.
Chondrosarcoma is the second most common primary malignancy of the bone and is usually seen in patients in their 40s or older. It affects mainly the axial skeleton, such as the spine or the pelvis, or it can also affect the proximal parts of femur. It usually involves the metaphysis, and chondrosarcoma is usually developed de novo, but they can also develop secondarily from enchondroma, osteochondroma, chondroblastoma, fibrous dysplasia, or Paget's disease. This is a gross picture of osteochondroma affecting the long bone. You can see this is the metaphysis area, the epiphysis and the diaphysis. So you can see the tumor just protrudes out from the cortex, and it has this lobulated appearance of hyaline and myxoid cartilage. So histologically, you can see lacunae, just like in normal cartilage, but these lacunae are abnormal because it has more than one nuclei within it, and it still has the cartilaginous matrix production, this bluish material. Clinically, chondrosarcoma presents as deep, dull, achy pain at night with pathologic fracture. It can have nerve dysfunction. It is a slower growing tumor compared to osteosarcoma, and because of this, it do not respond well to chemotherapy, and the treatment of choice is wide surgical excision. Grade 1 chondrosarcoma rarely metastasize. Compare that to grade 3 tumors, where they have a 70% risk of metastasis. Fibrous dysplasia is the tumor of the bone that occurs usually during the period of skeletal growth within the age of 10 to 25 years old. The anatomic site of presentation are the long bones and the jaws, and it can affect the diaphysis or metaphysis. This is a common benign fibroosseous tumor which is characterized by intramedullary location. All forms of fibrous dysplasia result from gain of mutations in GNAS1 gene, which encodes the stimulatory alpha subunit of the G protein. The resulting active G protein promotes cellular proliferation and disturbs the osteoblast differentiation. There are three types of fibrous dysplasia. The first one is monoostotic, which involves a single bone. The second one is polyostotic, which involves multiple bones. And the third one is polyostotic with endocrinopathies, which is associated with cafe au lait skin pigmentation and endocrine abnormalities such as precocious puberty, pituitary adenoma, and hyperthyroidism. This is a presentation of McCune-Albright syndrome. The polyostotic lesions may develop sarcomatous change. This is the gross appearance of fibrous dysplasia. The lesion is generally well circumscribed with grayish homogeneous surface. And this is the histological appearance, which is described as having a Chinese characters. The woven bone that is within the tumor is mimic the Chinese characters, and the bone lacks the prominent osteoblastic rim. The surrounding stroma is composed of fibrous tissue. Fibrosarcoma are fibroblastic collagen-producing sarcomas of the bone. It affects the middle-aged and elderly and is seen around the knee most often. It affects the metaphysis of the bone. Fibrosarcoma usually arise de novo or may arise as secondary tumors in pre-existing benign tumors, bone infarcts, Paget's disease of the bone, and irradiated tissue. Grossly, these tumors are large hemorrhagic tan white masses that destroy the underlying bone and frequently extend into the soft tissue. Fibrosarcoma usually have this herringbone pattern, which is seen in this picture. It has this central area, and you can imagine that the bone is jutting from the central area, similar to this mosaic. It usually presents as enlarging painful mass with or without fracture. Sarcomas arising from pre-existing lesions, such as Paget's disease of the bone, are more aggressive and has poorer prognosis. Next, we move to giant cell tumor, which is also known as osteoclastoma. It is a tumor that affects the young or middle-aged adults, and the majority of the tumors occurs around the knee. It affects the epiphysis and the metaphysis, and it usually is a benign tumor which is locally aggressive. The X-ray will show osteolytic features. Most cells within the giant cell tumors are the non-neoplastic osteoclasts and their precursors. The neoplastic cells are the primitive osteoblast precursors that express high levels of rankle that promotes proliferation of osteoclast precursors and their differentiation into mature osteoclasts. The absence of the normal feedback between the osteoblast and osteoclast results in the localized but highly destructive bone resorption. The giant cell tumors develop within the epiphysis and may extend into the metaphysis. The majority of them occurs around the knee, and they present grossly as this irregular dark red hemorrhagic mass which destroys the bone and is a lytic lesion. Usually there are numerous multinucleated giant cells that can be seen histologically with a background of small mononuclear stromal cells. Remember, the stromal cells are the neoplastic cells and the multinucleated giant cells are the non-neoplastic cells. The stromal cells, like these ones, have poorly defined cytoplasmic borders and their nuclei resemble the nuclei of the giant cells. Pain is the most common presenting symptom in giant cell tumor, and swelling and deformity are associated with larger lesions. Soft tissue extension is common, and the tumor can present with pathological fracture. 40 to 60% of the tumor recur after the curettage, and after treatment, patients with giant cell tumor should be monitored, as 4% of the cases metastasize to the lung. Now note, this is a benign tumor and they have the propensity or the risk to metastasize to the lung even though they are a benign tumor. They can be treated medically and surgically. So if they are treated medically, they are treated with denosumab, which is a monoclonal antibody against rankle that inhibits its binding to rank receptor, and this prevents the osteoclast formation. Aneurysmal bone cyst is a benign tumor of bone characterized by multiloculated blood-filled cystic spaces. ABC may present as rapidly growing expansile tumor. The features are similar to giant cell tumor, except this tumor usually occurs in the first 2 decades of life. It affects the metaphysis of long bones and vertebral bodies. Now you can see that in the picture there is a blood-filled cystic space here, surrounded by a wall containing fibroblasts, osteoclast-type giant cells, and reactive woven bone. Now, when they biopsy, this feature may resemble the giant cell tumor. Ewing sarcoma is the second commonest bone cancer in children and adolescents. It affects children and teenagers, and it is not seen in elderly patients. It affects the long bones, and it usually is seen in the medullary diaphysis of the long bones. It arises from cells with primitive neuroectodermal differentiation. Ewing sarcoma arises most commonly from a translocation of chromosome 11 and 22, resulting in the generation of fusion gene. This fusion gene results in abnormal cell proliferation and survival. This is a gross picture of Ewing sarcoma. This is the diaphysis of the long bone. And you can see this red-brown tumor breaking through the cortex. Okay, and histologically, you can see these small round blue cells similar to other primitive tumors like retinoblastoma and neuroblastomas. They have hyperchromatic nuclei with very scanty cytoplasm. Ewing sarcoma present as painful enlarging mass. They can be tender, warm, and swollen, and they often produce tender masses with fever and leukocytosis, mimicking acute osteomyelitis. They may metastasize early to other bones or other organs such as the lungs, liver, brain, and kidney. 80% present with localized disease, whereas 20% present with detectable metastatic disease. Treatment for Ewing sarcoma includes chemotherapy, surgery with or without radiation. In the past, the prognosis was poor, but with chemotherapy, 75% of children survive 5 years. The most significant factor to determine prognosis in Ewing sarcoma is the presence or absence of metastatic disease. The primary site of the tumor is also important in determining the prognostic factor. Distal extremities have a more favorable prognosis than those with central or pelvic sites. Age less than 15 years old has more favorable prognosis. The overall patient survival rate is around 60%. Now we look at metastatic tumors, which are the most common form of skeletal malignancy. Cancer can spread to the bone by direct extension to the bone, through the lymphatic or hematogenous spread, or by intraspinal seeding via the Batson plexus of veins. These are the paravertebral venous plexus, and it forms a direct communication from the peritoneum and the lower body to the cranial cavity and spinal canal. This represents an important pathway for metastasis. Any malignancies can affect the bone. 75% of skeletal metastases originate from cancer of prostate, breast, kidney, and lung. Any bone can be affected, but most commonly it is seen in the axial bones, femur, and humerus. There are 3 types of pattern seen in bone metastasis. It can be osteolytic, which is bone destroying, osteoblastic, which is bone forming, or mixed osteolytic osteoblastic. Osteolytic lesions occur when cancer cells produce substances that stimulate osteoclastic activity, such as PTH-related peptide. Prostate adenocarcinoma are osteoblastic, and most metastases are a mixture of osteolytic and osteoblastic pattern. In adults, metastasis to the bone occurs most commonly with breast cancer, lung cancer, kidney, and prostate cancer. In children, we see metastases from neuroblastomas, Wilms, osteosarcoma, Ewing sarcoma, and rhabdomyosarcoma. Metastatic bone lesions are typically multifocal, as shown in this picture. You can see the vertebral column with the intervertebral disc and the vertebra, you can see these whitish irregular lesions. These are the metastases, and they are multiple. These pictures show the osteoblastic type seen mainly in prostatic adenocarcinoma and osteolytic pattern of bone metastasis seen in renal cell carcinoma or breast cancer. You can see this is the outline of the pelvic bone that is normal, and you can see this more pale blackish area which represents bone destruction. Metastatic bony lesions are prone to pathological fracture. You can see the tumor is destroying the normal bone, so the bone will be more weaker than the normal bone. For the last part, we talk a bit on soft tissue tumors, which are defined as mesenchymal proliferations that occur in the extraskeletal non-epithelial tissue of the body. They are classified according to the tissue they recapitulate, whether it is muscle, fat, fibrous tissue, vessels, or nerves. So in contrast to carcinomas, sarcomas usually metastasize via hematogenous spread, carcinomas via the lymphatic spreads, making the lung and skeleton the common sites for sarcoma dissemination. The nomenclature for soft tissue tumors are according to the tissue of origin. If it is a benign tumor of adipose tissue, it is called lipoma. If malignant tumor of adipose tissue is called liposarcoma. There's also leiomyomas for smooth muscles, rhabdomyomas for skeletal muscles, fibromatosis for fibrous tissue, hemangiomas for vascular tissue in origin, and schwannoma for peripheral nerve tissue. That's for benign tumors, whereby you just add on a sarcoma at the end for malignant tumors. Lipomas are the most common soft tissue tumor in adulthood, and rhabdomyosarcoma is the most common soft tissue sarcoma of childhood and adolescence. With regards to prognosis of a sarcoma, it requires accurate histologic classification. And for many types of soft tissue sarcomas, the histologic rate is important. Staging helps determine the prognosis and chance of successful excision of a tumor. So in general, tumors arising in superficial locations, such as from the skin and subcutaneous tissue, have a better prognosis than deep-seated lesions.